This is Evelyn and I's orientation and attention intervention following brain injury presentation. So we're going to go over the summary of findings, future study ideas, application to OT practice, and our discussion questions. So the articles that I found were level 1 systematic reviews, and the article 1 research question was, what is the evidence for the effectiveness of interventions to improve arousal and awareness for people in a disordered state of consciousness post-TBI? Article 2, again a systematic review. The purpose was to determine the effectiveness of interventions addressing cognitive impairments to improve occupational performance for people with traumatic brain injury. And the third one, the purpose was to evaluate the effectiveness of sensory stimulation to improve arousal and alertness of people in a coma or a persistent vegetative state after traumatic brain injury. So some general interventions that were included or discussed in the systematic reviews that I felt related to orientation and attention were unimodal, bimodal, and multimodal sensory stimulation, attention regulation strategies with or without goal and problem-solving training, direct attention training, attention process training, and dual task and task shifting training, group goal-oriented attention training, and then compensatory attention and behavioral remediation approaches, and then computer-based brain training. So a summary of the findings. Multimodal stimulation was a main finding. It was discussed in 2 out of the 3 systematic reviews, and for that, there was varying levels of evidence within their systematic reviews, but mainly around the multimodal stimulation, it was levels 1 and 2 articles. So what is multimodal stimulation? It's multiple, if not all, sensory systems being stimulated simultaneously. And the evidence of the effectiveness is in 1. It said that several studies suggest that attention tends to orient more easily towards sensory inputs that possess multi-sensory properties. Also from the same systematic review, multimodal sensory stimulation was more effective in increasing consciousness of patients in a minimally conscious state. For example, those who can follow simple commands inconsistently and have some gestural responses and purposeful behaviors than in people in a coma or vegetative state. From another systematic review that also talked about multimodal stimulation, it said that interventions that provide patients with a rich sensory experience may use a variety of contextualized stimulation to improve consciousness and have been found to support recovery of those with DOC, which is disorders of consciousness. Another finding that was talked about frequently was unimodal stimulation. Now, this was also in 2 out of the 3 systematic reviews. It had varying levels of evidence. And this tended to be a little bit lower level of evidence, like 3 or 4. So unimodal is similar to multimodal, but it is only one sensory system being stimulated at a time. And the evidence of the effectiveness is auditory stimulation has been most researched and has the most evidence behind it. And one of the systematic reviews said that the use of a patient's own name was more successful in eliciting a response than was a neutral sound such as a bell. And patients in a vegetative state were significantly more likely to localize to sound rather than those in a coma. More evidence. In one of the systematic reviews, 6 studies using the unimodal auditory stimulation were found to facilitate the patient's arousal and awareness. There was moderate strength of evidence for practitioners to include familiar voices, telling structured stories, then in comparison to the low strength evidence supporting incorporating familiar voices telling unstructured content, familiar music, and or verbal orientation. So another finding, and these interventions were only discussed in 1 out of the 3 systematic reviews, but the research behind them within the systematic reviews I felt came from stronger levels of evidence. It included 6 level 1 systematic reviews, 6 level 1 studies, 1 level 2 study, and then 1 level 3, so all pretty strong. So one of them was attention regulation interventions, and there's strong evidence supports attention regulation interventions with or without goal or problem-solving training. And then other interventions were direct attention training, attention processing, and dual task or task shifting training. And 2 level 1 systematic reviews concluded that direct attention training, attention processing training, and dual task and task shifting training improved attention regulation. So again, it was only in one of the articles, but I felt the research behind it was pretty strong. So summary of application for OT clinicians from the level 1 research. I think it's pretty important to know that the use of a bimodal or multimodal sensory stimulation is effective following brain injury to increase cognition and attention. Number 2, the use of auditory input, especially familiar voices following brain injury to improve level of consciousness and awareness of environmental stimuli, has some pretty good research behind it. And then also, I didn't talk about this much, but in one of the systematic reviews, it said to be mindful when wanting to implement interventions for orientation and attention with computer-based programs, as there's minimal evidence behind it and its effectiveness, but it is an up-and-coming intervention strategy.
All right, so my articles that I found specifically talked about executive functioning, attention orientation with the use of co-op. So the 2 different levels of evidence that I found was level 3 experimental, which was a randomized control trial for Article 5, and then 2 level 1 experimentals, single subject study for Articles 4 and 6. So the purposes for Articles 4 through 6, just to go through them quickly. Article 4 was to determine co-op's effect on adults with executive functioning challenges after TBI. Article 5 was to gather information pertaining to co-op and its effects on children with cerebral palsy or brain injury. And then Article 6 is to help understand the effects of the use of co-op in improving occupation-based goals of children and adolescents with acquired brain injuries. So the different interventions that were discussed, there was modified co-op, which was providing a visual of Go Plan Do Check for the children, along with working within the client's own homes, which increased, and then they also increased the amount of sessions to 20. It's usually 10. And then there was intensive co-op, which was 1 hour for 10 days in a small group setting with coaching from either the OT or the parent. This is with the children and the adolescents. Working on different occupations like dressing, leisure, like playing basketball was one of them, hairstyling, cutlery use, and more of what children and adolescents wanted to do. And then another intervention was just the traditional co-op for the most part. They did increase the sessions to 14 instead of 10. And it was bi-weekly for 45 minutes in separate clusters, depending on their executive functioning ability. So depending on if they could attend to the activity or if they could be aware. All right, so some of the summaries of the findings was that the increased amount of sessions, sometimes like doubling, increased transfer of skills and time ensured to complete goals for an individual with a TBI when improving executive functioning. Individuals who practiced co-op, they were the 50% best responders, performed better in attaining goals related to attention and orientation compared to those who were in a group. So the people who practiced on their own did better than if they were in one of the clusters of groups. Intervention of co-op was statistically significant for clients achieving occupational performance goals. They all used the COPM in order to look at the different satisfactions, the performance, to kind of create the different goals and the importance as well. And then metacognition is necessary for attention and orientation training through co-op. And the COPM was a strong predictor of significance in occupational performance prior and post intervention. And as I said before, all the studies used COPM. Okay, so the summary of findings for OT clinicians, what we can take out of these. So increased sessions for people who have had a TBI would be the most beneficial. Because it allows for that increased practice, which helps for better transfer, especially when working with attention or something that's difficult for the client, and even with orientation as well. Coaching is important with the client, whether that's us coaching them or the parents, and that's going to help increase their occupational performance and the satisfaction of the client. Transferring skills is extremely important. So practicing the skill in a familiar environment like the home, as well as the skill that they actually want to work on repetitively increases that transfer within different environments in general. And then motivation, ensuring that the client feels motivated towards their goal of attention and orientation by choosing an occupation that is important to them is essential. So choosing to work on ball skills, choosing to work on hairstyling, all of those are really important in order for the person who struggles with orientation and attention to actually do what they want to do. All right, some future study ideas that we came up with was more research on the effectiveness of computer-based programs on cognitive skill, so orientation and awareness, training following brain injury, determine the most beneficial time of when to begin initiating interventions following brain injury. Should we do it right away? Should we wait a month? Should we wait a week? Determine how long an intervention with co-op lasts for attention and orientation. There was post 3 months after, but nothing more than that. So trying to figure out, does it transfer even longer? Do these skills remain retained? And then determining the efficacy of co-op for an individual with metacognition difficulties and other cognitive comorbidities after TBI. All right, and here are discussion questions. Number 1, multimodal sensory stimulation was found to be very effective with increasing attention orientation. What is one way that you could stimulate each of the 5 senses in this approach? And then number 2, describe a case scenario when you would want to use unimodal stimulation over multimodal stimulation when addressing orientation and attention. And then number 3, how can you maintain the validity and reliability of co-op when modifying the model to create the best fit for a client depending on orientation and attention? And here are our references.